excellent talk. And it was such an excellent talk that I'm rescinding my talk of always doing ALL. I'm actually going to take the chairman's prerogative and talk more, kind of like the last talk, more of a philosophical approach to ALL. And what do I really think about it? You know, the ALL, and Volker's a good friend of mine, has a lot of hype to it, and it's a fad. It reminds me very much of double bundle. But you have to look at ACL surgery from an historical context. And that's how I want to think about this. And if you look at ACL surgery from the past to the present to the future, I think we will all see that, first of all, this is not a new concept. They did lateral extra-articular tenodesis 30, 40 years ago, and guess what they did? They overconstrained knee and created a lot of lateral arthritis. So an ALL is not a benign concept. One thing that Sachin did gloss over was how he tensions his knee in 60 degrees of flexion. That's a really debatable concept. That's in itself. I don't really know how to properly tension an ALL. Is it 30 or 60? And my biggest fear is overconstrainment. So I think it's a fascinating subject. I would say, if you want to say that I am an ACL surgeon and I do ALL reconstructions, I do probably more Lemaire's because I'm of an Al Get Good philosophy. But let's talk about how we got here. So when I was a young surgeon, heck, my own knee, you know, the 70s was 2-incision ACLs, right? 2-incision ACLs worked really well. Why? Because you could never do a vertical femoral tunnel because you drilled outside in. Outside in ACLs is actually coming back. It just shows you how schizophrenic ACL surgeons are. We reinvent the wheel all the time. So this 2-incision was actually a very good construct. But then in the 90s, we went all arthroscopic, right? We went all vertical ACLs. It was very quick. You could do a transtibial, but what did the transtibial ACL did? Well, it made a relatively vertical femur. So we thought all the problems were solved, right? And then we only talked about was hamstring VTB. Guess what? A big concept, which wasn't talked about today yet, is a lot of the concepts of ALL reconstructions are based out of France using a hamstring graft, right? In the United States, and even in high-grade Premier League players, most people are doing patellar tendon grafts. So when you tease out the need for doing an extra-articular tenodesis based off graft type, it's another highly important variable that we have to talk about. So then we talked about outcomes of ACL, right? We did great. So if you put a really stiff graft in, they did awesome, right? Well, no, we overconstrained the knee. You lose extension, you get arthritis, or you did a lateral extra-articular tenodesis, you got arthritis. Arthritis really became a problem because probably also, to go back to our first talk, we took out too many menisci. So what was the problem with the all-arthroscopic technique? Well, anatomy got compromised. We did a non-anatomical tunnel drilling. We did a vertical femur, and then we moved the tibia back posteriorly, and we got rid of this clock face. This is a paper from HSS showing really what a classic non-anatomical ACL. So what's going to happen next? What's the next thing we're going to do? We're going to get anatomical, right? Who's going to get us all anatomical? Well, it was Freddie. I was a fellow with Freddie, and we went from grafts way down here to grafts here. We heard from one of our speakers about double bundle, right? Double bundle was the answer, right? Let's prevent roof impingement. Let's put lower grafts. Now, if you do a lower graft, you're preventing superior impingement, but you're actually getting roof impingement, right? The most horizontal graft you can get is a pediatric graft, right? And that graft sees a tremendous amount of strain. So we have MRI data to show that there's actually a sweet spot, that being too high is bad, but being too low is bad as well. So we're quite schizophrenic. We can't decide where to put a graft. We can't decide what graft to use. And now we've invented a new graft on the outside of the knee. This conversation is just getting more and more complex. And this brings up the concept of the clock face. So the one thing Freddie did teach us, right, that probably we were going too high. Anatomy, we should focus on anatomy. And then he brought up the concept of a double bundle. The double bundle, for the most part, in the United States has come and gone. It's still very popular in Asia, as we heard before. But the concept of double bundle brought us really focusing on anatomy, on insertion sites, on proper tensioning, and kind of tailoring the surgery to the patient, right? Tibial slope, lateral meniscal status, and overall meniscal status has to all be addressed on each ACL. You can't do cookie cutter ACL surgery just right. Every total knee is not is different. You got to really take out a lot of different variables and do the right operation for the right patient. So now we get to the ALL. Well, Andy Williams came to HSS a few years back, and Sachin was kind of talking about Andy Williams is one of the most famous Premier League physicians, and Andy did BTBs on all these high-level athletes, and then he started adding a Lemaire, and he found really improvement in his re-rupture rates. He didn't find it was a highly morbid operation, and his knee stability. Then Andrew Ames came a lot about it. Now, ironically enough, Andy Williams is backtracking and saying, maybe I don't need to do it. Because if you use a stout graft, you don't necessarily need to have a lateral stabilizer. So what is my concept of the ALL? What did Segund teach us? Does every ACL tear have a Segund? No. Only a high-grade ACL has its Segund. And if you have a high-grade pivoting motion or a high-grade tibial translation, if you look at Clace's original paper, look at the tibia relative to the femur. This tibia is dislocated. The only way you'll see these fibers take tension if the tibia is dislocated. And not every ACL goes that far. If it does go that far, you'll get an avulsion, you'll get a Segund. That's why if you do have a Segund, it's a high grade, it's a high pivot, it's a high translational event. So, what's my first concept? Well, not every ACL needs a lateral tenodesis. I think we're all gonna talk about that. But if I do thinking that this patient has lateral meniscal loss or a tibial slope problem, and I'm not doing an osteotomy, well, if I want to dampen this ability, because the ACL takes load here, but once you're almost subluxed, I want a secondary stabilizer. Well, maybe there is a role for having some collagen on the outside of the knee. And what are the biomechanics of, as we heard, the lateral stabilizer prevents internal rotation, and it's really a measure of a high grade or a high subluxar ALL injury. So what are my kind of pearls for it? First of all, I want everyone to separate in their brains a reconstruction versus a Lemaire, which we heard a little bit about that. I'm more on the Lemaire side, but certainly as Sachin pointed out, you can do a very elegant percutaneous reconstruction, whether you use the same graft or use a unique graft. The French school use the same graft, use a gracilis, but you can also use a unique graft, and you can do a femoral socket and a tibial socket. My problem with using a true graft is I don't know where the femoral insertion point is, and Sachin pointed out that neither he does. So it's hard for me to drill a socket if I don't know where that socket should go. So that's one of my hesitations about doing a recon. How do I do a Lemaire? I do a lateral skin incision. You don't have to release the perineal nerve, and I take anywhere from a 6 to a 9 millimeter wedge of IT band. I strip it, and then I go under the LCL here, and then screw it on top. If I am doing a true ALL, I will do a femoral socket, and then I will do a button on the other side. I think the critical aspect of this is getting your bungee cord effect by tethering the LCL. So really going under the LCL for a Lemaire, to me, is improving the biomechanics, and that's what Al Getgood has shown. If I do a femoral socket now, I've gone away from using a screw, and now I'm using more of an endo button on the medial cortex. Tensioning. Tensioning to me is really the most controversial point, because lateral arthritis, which we had at HSS, was a big problem. So if I have a tight lateral compartment, my threshold to do a Lemaire or a reconstruction gets lower. I also don't know, there's two schools of thought. There's a low flexion angle, which is 30 degrees, and then there's a high school of thought of 60 degrees. Also, how much tension can you do? You know, they say 20 to 30 newtons. How is Sachin or anyone tensioning at 20, 30 newtons? It's hard to figure that out. That being said, I do Lemaire's, but you really want to exaggerate Sachin's point, is that this is supposed to be an extension concept. So if you have tension of your system in flexion, it can overconstrain the knee, and you want to prevent that. And this is kind of tunnel anatomy using a CT scan. So here's, I think, a controversial topic, but the best way for me to teach young surgeons what you should do. Here's a 15-year-old kid, open growth plates, so I don't really want to use a patellar tendon on him, and he has a Segund fracture. So historically, people would just do an ACL. And here you can see the whole avulsion. So this guy had a high-grade ACL. You can see a big bone bruise, and you can even see bone marrow edema where he fractured his IT band complex, right? Because that's what Volker's group would talk about in Pittsburgh. We don't call it the ALL, we call it the IT band complex. But if the pivot is created by the IT band, well, why don't we fix this? So now, all my acute seguns I fix, and even chronic ones. I'm getting a tenodesis effect, and I do these routinely. And it takes 5 extra minutes, and that's a regular hamstring. All my ACL revisions with lateral meniscus loss, I do a Lemaire on now. It's a very low morbid procedure, but you can get a hernia on the outside of your knee, so you have to still be careful about that. I think there's a lot of data here. We're running over time here, but I think the data is pretty clear that adding an extra constraint can times 0 hold the knee a little better. But I will also really look at, it really depends on what graft you're using. So I think acute repair for seguns is appropriate. I think doing a Lemaire for revision ACL is appropriate in the setting of tibial slope and meniscal loss. I think doing ALL reconstruction in a setting of a hamstring graft, which is usually a slightly inferior graft in terms of high-level cutting sporting athletes, is also appropriate. Thank you very much.